Tēnā koutou katoa, ko Pirongia te maunga, ko Waikato te awa, no Kirikiriroa ahau, Nai Tahu te iwi, ko Karen Evison toko ingoa. And thank you for inviting me. I'm going to probably go blah blah, and I'm using Ministry of Health slides because I asked someone else to pull this together for me, because I've been out in New Zealand, rural New Zealand, remote New Zealand, talking about childhood obesity and trying to find some solutions and some local examples of where things are going fantastically. And it was great to hear Karira and her whānau talking about what they're doing, because that's a key to the solution. This is multifactorial, it's multi-sectorial, and there's not going to be one single solution. And the health target by itself is most definitely not going to be that. So just as a bit of an overview, the government announced the package in October last year, and it really was to start to think about focusing some of the health system and the other systems' attention on what we were seeing with the growing number of people with obesity in New Zealand, and trying to target it at the beginning of a whānau journey or a family journey, and looking at the life stage and where intervention might be able to make the biggest impact for future contribution to life, to culture, to society, and to health care. It's set up in a triangle, and this is sort of to focus the country on the areas where the biggest potential gains could be made. So we have our broad population health approaches, and this is all the things like Whānau Ora, Healthy Families New Zealand, eating and activity guidelines, what Play Sport does, what Sport New Zealand does, what education does, the general public awareness campaigns that we see. There are a lot of things that have been happening for a long period of time, and there are things like breastfeeding initiatives and others that all contribute to what's happening in the broad environment to help set the platform for what we're doing and talking about. There's an area in the middle where we need a bit more increased support, because we know it's preconception, it's before mother and father decide to have the baby that a lot of the platform and the genetic changes occur around what's going to happen for that child or that family when they're born. Do we have a really healthy and vibrant pregnancy? Do we have the mum and the father set up to have that healthy and vibrant pregnancy? And do we have all the supports in place to help optimise that? And then right at the top is the targeted initiatives. What are we doing for those children and those families in whānau that are already in crisis, that are already exhibiting quite serious risks of obesity at that point in time? So the health target, I went past it. That's how exciting it is. No, the health target. So the health target is going to be called Raising Healthy Kids. And the icon's up in the far top side of the slide there. And it's to try and take away the focus of the clinical terminology, obesity. It's not one that tends to bring warm feelings to one's heart when we talk about it. But the whole intent is to raise healthy kids in New Zealand. The target is quite specific. It's about a little bit of the process, and it's actually an enabler for a conversation and for a community and for a district and for an area to start to think about what the contribution will be and how do you join that up. How do you turn it into something professional? How do you create systems? And John talked about that a little bit this morning with the tobacco target. It's important that it's taken in context. There's lots of well child and tamariki ora checks of weight right the way through up into the age of 4. It's not just about the 4-year-old check, which happens to be the one that will be in the newspaper. And there's lots of points in time throughout that child's journey and that whānau's journey with general practice where further checks of weight and progress can be brought into play. I used to be involved in the tobacco control target way back when it was first announced, and recognise many of you here from that journey. And it was about starting the conversation and keeping that conversation going. And we had a scenario then where the health system was ignoring or not actively having conversations with people about smoking. And so it was sort of making it a bit contradictory when they were hearing messages in other parts of society that smoking wasn't so great. So it's just having that clinical checking through. And there are there are clinical risks to being overweight that need to be checked as we go through as well. Māori and Pacific children are as likely, if not more likely, to be referred at the moment if they're turning up into the system obese or overweight. which is a really good thing, and we want to make sure that those services are targeted, that are specifically built and or appropriate whānau and community. John talked about wanting feedback on referrals for when you're sending things to a cessation provider. And just like that, the before school check providers really want receipt of referral and acknowledgement of what's happened with these children and families when they've sent them on for their referral for both the health assessment and the family-based nutrition activity programs. There will be different approaches and different referral options for the country, and that will depend on what your current resources are, what your current services are, and only you will know what those are. But it's around having a systemic approach so that general practice and all the health professionals who are doing the clinical checks of these children know where to send family and whānau and have confidence that the services will all tie up, because people hate being moved on when they're dropped or there's miscommunication or there's problems with that carry on and continuity. These solutions might not be health solutions, and in many instances they won't be health solutions. There'll be things that are happening around parenting courses, they may be community gardens. The example of the whānau initiative we've just talked about, they're all active and possible and feasible solutions that should be part of what you're thinking about with family-based nutrition activity and lifestyle interventions. Don't just think health. The recommended referral pathway that exists, it's in the Well Child Tamariki Ora framework at the moment, is going to change because we're updating the guidelines. At the moment, it says that most children, or all children over the 99.6th percentile should be referred to paediatrician, but that's only if the health assessment can't be done in the general practice community or in the primary care or community health community. That's looking at those complex children with complex health needs, not necessarily for the weight management component of what the child and the family are there for. That can be well dealt with outside of the specialist hospital services. It's really important things like obstructive sleep apnea in particular are thought about with these children when they're coming in presentation, because if they're not sleeping well at night, they're not going to be learning, they're not going to be vibrant, ready for school young children. At the moment, the prevalence, this is the October to December period for the country, shows that we were sitting around 10% of all children in New Zealand are obese. For Maori, that's 14%, and for Pacific children, that's 25%. So we do have variation in the country, but not significant variation across all the district health boards, and there's some obvious outliers with counties Manukau and areas where there are high Pacific populations. The percentage currently of obese and overweight children who've been referred, and that includes an acknowledgement of that referral for the country, is sitting around about 23%. But as you can see by the country, there's a variation of 3% in the Bay of Plenty up to nearly 40% in Northland. So there is quite a lot of variation, and there's a lot of improvement we can do across the country. But our challenge obviously is to try and get to 90%. That'll be fun, won't it? So what does this mean for us and for the sector? It means a collective responsibility. It means a collective response. It means building networks, strengthening networks, using relationships to build the most appropriate place for these children and families. In New Zealand, we're talking about 4,500 children. It's not a huge number when you look at it in real terms, but that means it can be individualised a lot more than perhaps something that we're dealing with this more heart and diabetes, where we're up in the 500,000 people. It needs to be appropriate, there needs to be follow-up, and this needs to be a lifelong, life course approach for this family and this child. The target is most definitely not the end game. If the target is the end game, we've completely missed the point. It's really important that primary care is part of the solution. It's not the only place that the solution, and generally it will be in the NGO, the voluntary sector, the sports sector and the education sector. But GPs are really important around just providing some of the levers and the extra motivation in different ways to why people may want to engage with changing behaviour. I'm just going to talk about Farno Party. It's a program that's been run over in Taranaki. It's received some funding from the HRC, and it's looking at a different way of providing active families support and intervention for, at the moment, children aged 15 to 16 years, 5 to 16 years, I should say. It has quite a multidisciplinary team involved with it, and they act as the referrers for the Green Prescription Active Families program. It's one-on-one family support, and it's based in the family's home. So it includes things like ongoing assessment. It's looking at the whole family, not just the children, cooking sessions, fitness assessments. And the referrals have closed. They went up to 300 referrals, and the program officially ends at the end of July. And we just met with the providers last week and asked for some of the critical success factors, and none of these will be a surprise to any of you in this room. Clinically led childhood obesity, or a clinically led focus on the child's obesity, was really helpful. People like to have milestones. They like to see how they were progressing and in some of the technical components of what they were doing. A multidisciplinary team is really important, and that team needs to have access to all the different relevant clinical records to help support optimal management. And the multidisciplinary team, we're not just talking about the traditional doctor, nurse, dietitian. It might be much broader, with community workers, kaifina and others involved. The home visit model, which could also be marae-based, is really important. This is about going into the family or whānau's home and seeing what it's like for that family and whānau to live and to behave, and how the challenges are going to be, and what sort of things are going to engage them in wanting to make change. Māori and Pacific engagement is absolutely vital. That's no surprise. And a database where everyone can share putting information in together so you can see what everybody's up to is really important. What it has showed is even a really quite light touch, low intensity intervention of just visiting the home and providing ongoing assessment and regular checking by telephone with these whānau have appeared to lead to an ongoing and sustained reduction in BMI. So there are ways of incorporating some of these concepts into programs and initiatives that are already running, and I'm well aware of, in tobacco and cardiovascular risk assessment, diabetes, across the country. To date, we've visited 13 regions so far around the country, and we're still in the process of getting to the last few. Health, sports bodies, iwi groups, NGO groups, councils, everyone's collectively looking at how you can best respond to the target and meet the point rather than the target, and reduce childhood obesity within the region. Everyone's looking at their health pathways or their referral pathways, the systems that they've got in place for referral pathways, to ensure that there's a seamless and automatic professional approach to how these families and children are moved through and around the system in a way that is integrated. There's a recognition that different things will need to happen at different times for different communities, and that's really important. Natalie, who's going to talk next, is going to talk about some resources and tools that they've developed in the Waikato that are really, really useful to help support and keep people engaged and motivated, because the workforce is really a little bit anxious about talking about this as well. You know, it was the same when we started with smoking. People didn't want to ask about smoking because what if I get into a conversation that's about a whole heap of things I don't have control over? It's the same for weight and obesity, but we have a fantastic smoking cessation workforce. We have a fantastic training program for smoking cessation across the country, and that can equally be applied, the methodology and the theory behind that, to talking about weight. And Gravada also does some specific weight management and weight conversation training across the country as well. We do need to look at other key touch points, and teenagers and sexual and reproductive health is another area that conversations about weight and preparation for birth, which might not be completely at the top of their list at that point in time, but is a really important intervention moment as well. So I guess the take-home message is really to reiterate what John said this morning. It's about providing professional practice, the health system being coordinated and organised around how we're going to work with people, and particularly children and families who are overweight and obese, and to translate some of the learnings that we've taken from the smoking cessation target and the Mohan diabetes target, which are both also preventative health messages, into this childhood obesity. It's an opportunity for us to do better than what we've done before. It's an opportunity to pick up on many of the things that you've discussed and you've pointed out at the table conversations today, because this is a relatively small group of people, And it comes back to what the local solution, the local plan and the local response needs to be. There's no way we're going to produce a national referral pathway and thou shalt all follow thy referral pathway. It's just not going to work for these particular children and their families. That's me.